hopefully more people will start to trickle in as time goes on. I'm really delighted to see some people in the audience that are colleagues, mentors, and friends. And it's really an honor to have such a great panel join us today to talk about their experience in starting robotic colorectal surgery programs. I just wanted to briefly introduce my co-host today. Dr. Mira Abu Khalil is a fantastic colleague and friend who trained in McGill and is a colorectal surgeon in Montreal. And previously was a robotic enthusiast, but is shortly starting her own uh, learning curve and journey with the robot here shortly. My name is Amir Farouk. For anyone who I think I know most of the people on the call, but for anyone maybe who doesn't know me, I'm Amir. I'm one of the colorectal surgeons at Queen's University. So I wanted to talk a little bit about this robotic surgery collaborative, or the ROBOCO, or it's almost RoboCop, we're just missing a P, but ROBOCO collaborative that we've developed. And I'm really, really hoping that this can be the first of many webinars and many collaborations and many projects that this group of motivated people can do, and some really powerful things can come out of this collaborative. So just to kind of outline the evening, we're hoping to keep this relatively short, about an hour or so. Our panelists, who Dr. Abu Khalil will introduce shortly, have prepared relatively short talks. We've kind of forced them to make relatively short talks, but the main reason for that was really to allow for some time for discussion, because I think many folks in the audience will have some insightful questions about actually developing a program. I just wanted to take 2 minutes to talk about ROBOCO, and then we'll get going with the panelists. So, part of the inspiration for this collaborative came after we had Justin Dimmick attend our research day at Queen's University. I think he's no stranger probably to many of you. He's currently the new Annals of Surgery editor-in-chief. He's done amazing, amazing things. He's the chair of the Department of Surgery at the University of Michigan. And he's, among his many achievements is the development of the Michigan Bariatric Surgery Collaborative. This is an amazing group of people that would meet in Michigan every year, and they're all bariatric surgeons that all get together and work together to collect data and to look and see how they could improve their own outcomes. And some amazing things have come out of the collaborative. One of them that I loved is this seminal paper looking at the link between surgical rates, and that really came out of this collaborative. And so what I'm hoping with ROBOCO is to develop a collaborative of Canadian colorectal surgeons who can unite together in trying to improve outcomes for our patients, specifically with robotic surgery, but perhaps more broadly with colorectal surgery patients across the country. I'm many people on the panel and in the audience were involved with things like the rollout of TATME, and we've learned from the experiences of adopting new platforms that we can run into new issues that we've never seen before. And we're hoping that perhaps we can be a bit more deliberate about the way that robotic surgery can get rolled out across the country, and have it rolled out in a way that makes sense for a Canadian context, and ultimately serves our patients. We have a lot of big dreams and aspirations for the collaborative. We're hoping that this collaborative can assist with the implementation and development of robotic programs across Canada. We want to collaborate to collect data on robotic surgery patients, and use that data to improve patient outcomes, and of course research, and really to provide surgical coaching and mentorship. And one of the big components of this, hopefully, will be the webinars that we'll put on a semi-regular basis to talk about how we approach different cases and really get into the nitty-gritty of how we set up these our robotic cases. We really believe that we can improve the quality of care in Canada through collaboration and collegiality. And I think we're very unique in Canada that although we're geographically disparate, our community is actually very tight and relatively small, and I really think that we can do some amazing things. We're currently in discussions with Mark Solomon and the Surge On platform to see if we can perhaps even make a group on that platform that can allow us to seamlessly share videos, cases in a HIPAA compliant or a confidentiality compliant way, and that can change the way that we really discuss cases, talk about common problems, and move our programs forward. So we're really hoping that all of you can join us on the line. If you have any questions, please feel free to email or text, call either myself or Maria, and we'd love to add you to our mailing list and get you on board. So with that, I'll hand it over to Maria.
Awesome. Thanks a lot, Amir. So our first speaker, maybe like all of our panelists today, doesn't really need an introduction. So Dr. Qureshi is a surgical oncologist who's an associate professor at the University of Toronto, and will be talking to us about getting the robot. So essentially how to acquire a robot specifically for the use in colorectal surgery.
Great. Thank you so much, Maria. Let me just share my screen. Ooh. Let me see here. My apologies. Hold on one second. Like all things, technical challenges. I'm going to try one more time. My apologies again. Here we go. And let me know if you can see my slides.
We can see your slides. You might have to just put it in presenter mode or share mode. We can see your notes, which is fine with us too. Look like his screen is frozen. Just give it a minute.
Oh, can you hear me still? I apologize. Give me 1 second, folks. Like
We're just gonna sit. We're just gonna sit and admire the suit, the tie, the watch. The whole ensemble is fantastic.
Well, I have to say, like these pictures you put as our promotion, Fayez is always just like a model coming from New York City. Like amazing, amazing work,
Well,
Fayez. That's why you get all
don't
the
worry,
money.
yours is pretty good too. There's a very soulful look, you know. It's good. Your
Contemplative.
picture's pretty good. Yeah, it's very good.
Okay, now I think I'm on here. Can you see the screen now?
We can definitely see your screen. We can see your notes, but that doesn't matter.
There we
Oh,
go.
that's
I
good.
think you're
There you
good.
go.
Yeah, perfect.
Perfect.
So I'm sorry. You know what? It's a classic scenario, folks, of where technology either loves you or hates you, and I have a love-hate relationship with it. Fortunately, not a love-hate relationship with the robot. I mostly love it. Thank you so much, Maria and Amir, for having me join this esteemed panel, and it's really nice to see so many familiar faces and names across the table joining us in the conversation today. I know, Amir, you put up in terms of the topic of the presentation is acquiring the bot, and I've just modified it subtly to include a bit of considerations as it relates to technology adoption and diffusion broadly, and thinking about institutional considerations. And I'm putting on a bit of my surgeon hat as well as my administrative hat and saying, how do you position and ask? And what are some of the things that you want to contemplate as you think about looking for a robot investment at your respective organization? And so, as introduced, Fayez Quereshy, I'm one of the surgical oncologists at UHN in Toronto. I also am one of the clinical vice presidents, and I'm responsible for the surgical portfolio here across the network, and a cancer surgeon here at UHN as well. So an interesting piece here is just looking at adoption of robotic surgery in general surgery broadly across the US. This bar graph demonstrates different subspecialties that use robotic platforms for different types of intervention. And you can see the year-over-year growth from 2016 to 2022 is quite substantial. What's also quite interesting is that even though we think notionally in Canada that the robots are predominantly utilized for urologic cases, and prostatectomies, I think, are the ones that are hallmark thought to be robot related, you can see that the proportion of cases being done by general surgery have actually overtaken other subspecialties in the use of the robotic platform. And in 2021 alone, 700,000 general surgery patients in the US were treated with a robotic platform, which is remarkable if you think about it. And when you start to think about the adoption curve and some of the cases that are considered either early market mainstream market or mature, no question, a good proportion of the general surgery cases, the colon and rectal resections, those are the ones bolded in this slide. But ventral hernia repair, inguinal hernia repair, some gastrectomy, hepatobiliary cases are now deemed to be mainstream market, whereas the mature market are really in the urologic and gynecologic spheres. But if you start to juxtapose that to what's happening in Canada, it's a very different narrative. And our adoption of technology has been significantly impaired relative to our partners south of the border. So in total, only about 50,000 patients since 2003 have been treated with robotic platform overall. And if you look at the number of robotic surgeons across the country, there are about 240 trained individuals across 13 cities in 5 provinces. Only 29 hospitals, and that number may have grown in the last 2 years, but this data is of deep 2022, early 2023. Only 29 hospitals actually have robotic platforms. So really only 1 to 2% of all surgeries are performed with robotic assistance. Now, if you actually zoom into general surgery specifically, in fact, over the last 20 years, only 1,850 surgeries have been completed using the robot. That's a very small number. And it represents about 0.05% of all general surgical procedures done across the country. But I would say innovation is critical. And you may say, well, Fayez, why is innovation so important? Well, why not stick with the current paradigm? Well, I think there's a natural evolution in wanting to do things better, faster, and cheaper. And so we in Canada tend to look for hard evidence to justify that innovation curve in order to adopt new technologies. And for many of us, certainly in the oncologic sphere, those hard metrics relate to overall survival and disease-free survival. Now, we know from the laparoscopic era that actually demonstrating improvements in overall or disease-free survival using modality is quite difficult. What we've failed to actually incorporate in some of our thinking are patient-related factors, quality of life, improvements to the provider. And when we start thinking about those domains, and then starting to couple in some of the economic considerations and efficiency considerations, we know that innovation can be an important agent to help us advance forward. Now, robotic surgery in Canada has really been, I would say, victim of this innovation philanthropy trap. And I know it's not a common term used, but I would say that we have relied on generous donors to help support robotic surgery across the country. This is not a unique phenomenon in Canada alone. And I've referenced, in Ontario alone. And I've referenced a few different examples across the board of where philanthropy is used. And you can see these are all really important articles that are in the lay media that have outlined the importance of robotic surgery. You'll see in the top right-hand corner, I've given a shout out to my colleagues in Kingston as they were cited as being obviously a key leader in robotic rectal surgery across the country. So when you think about institutional considerations, I know we often think about, well, can we demonstrate that it's cheaper? And can we demonstrate that we're improving throughput or efficiency? And I would position to you that thinking of the economic game alone is not the strategy. Because if you were to put things back, forward to administrators about the dollars and cents of our business, it's unlikely to see that the robotic platform is going to win on all levels. Now, you might argue, well, the episode of care as opposed to the cost of care in the operating room is what wins out. If you can abbreviate length of stay, decrease complications, minimize ICU admission, reduce transfusion, that'll all translate to better care and better outcomes and therefore reduce cost. But when you start to do a head-to-head comparison with laparoscopy, it's really hard to tease out some of those differences. Now, if you're going from a predominantly open context to robotic, that is a different conversation than if you're migrating from laparoscopy to robotics. And so I would say thinking about the economics alone may not be actually enough. And I would suggest that we think about other institutional associated considerations in thinking this one through. So the first is, as you think about the mission, vision, and values of your organization, does technology and innovation line up with your organization's ethos? Is it a part of the DNA? Now, many academic institutions would say absolutely, but when you look at some of their adoption curve and some of their uptake of technology, it tells a different story. But really, it's thinking about what defines the principal motivators in your organization. And is this one that's a fundamental tenet? And speaking to administrators, CEOs, boards, and lining up the language associated with the organization's ethos and mission is a really important and powerful angle. I would say that the other piece in this is, have we got the appropriate quality and safety metrics? So Amir was referencing this with the adoption of TATME and other modalities, that sometimes we do so with quite a significant amount of fervor. But have we thought through all of the potential safety considerations? And the collaborative in Michigan that looked at quality assurance is a really important one. And I would say that certainly at the institutional level, you want to be thinking about a mentorship platform as you bring forward on new technologies, quality assurance and evaluation, and then recalibrating. And so the question would be, demonstrating to your leadership that in fact your organization has a quality and safety structure with procedures, policies, credentialing that enables you to hold up a commitment to patients. And that would help soften the introduction of new technologies. Now, the interesting one is industry. And I was scanning the list, Maria and Amir, to see if there were any industry colleagues on the call. I didn't see any, which I think is a good one, because industry plays a bit of a razor's edge relationship with us as we fuel innovation. I would say about 20 years ago, 70% of innovation that took place in biomedical research was sponsored by the government of Canada. Now in 2023, 70% of biomedical research on the innovation space is fueled by industry. Now, there are pluses and minuses to that, but it really does put us on razor's edge. And there was a Netflix docuseries that was looking at this. I think it was called The Bleeding Edge. And it looked at, what is the role of industry in helping to influence the adoption of new technologies used in clinical care? And we have to be careful. Obviously, we should lever it to its advantages, the lobbying interests, the evidence generation, but at some points, these collide with clinical excellence and institutional ethos. What I would say is that government relations is also really important. And across the country, there's a bit of a different story. So as folks on this call will know, that in Quebec, robotic surgery in some form or another is publicly funded, as well as in Alberta, whereas in Ontario, robotic surgery is only variably funded. And there's a bit of an evolution taking place on what cases qualify for incremental funding. But across the board, it's not universal. And I think the differences in funding envelope have contributed to how we see the adoption of robotic surgery across the country overall. All of this together in terms of institutional considerations, when administrators are looking at this, they're looking at their mission. Is this safe? Have you actually related with industry in a equitable and appropriate manner? And is the government likely to sponsor this? All of these create a bit of a web in terms of our considerations overall. So I would ask, is there a concern about the inherent quality of surgical robots or the care of surgical robots and safety? Or is there an issue as it relates to the adoption of technology and the financial viability of this type of approach? And so when you think about adoption curves overall, I would say this is true for almost any type of technology that's brought in. And I would say if we bring up the TATME example, where the accessibility of the disposable instruments was relatively rapid, we had a very rapid uptake. So there was inflated expectations of what we could achieve and do. And I think for the most part, there continues to be a role in transanal TME-based surgery. But what that role might be different than what we perceived about 6 or 7 years ago. But I would say at the beginning for early adopters, if I overlay this curve on with a bit of some of the early market and mainstream market, you get a sense of where people are taking up some of this technology. And I think we are currently sitting in this chasm, that we're in this trough of disillusionment in some ways, where over the last decade, we haven't advanced robotic colorectal surgery or robotic surgery overall in Canada because of implications on cost, concerns about data, the training paradigm, which is why groups like this with ROBOCO can be so influential in helping to ensure smooth uptake in a variety of ways. So I would say, why is it important for us to position ourselves being robotically enabled? I think it's not exclusively what the robot provides us for today, but I would position is what the robot enables us next. So augmented surgery, artificial intelligence, image guided and image intensified. We do need to safely deviate from the innovation curve without hard evidence, but with the promise of some improvements that may not be conventional ones. And we may have to realize that not all hospitals need robots right now, but I do think a collaborative is really important to move this forward. So I'll end by just putting so now you've said this is aligned with our organizational priorities. How do you structure a pitch? And I would say the first thing is set the context and situation for your administration. So this is Organization X, has 2 robots. They've got 1 intuitive, they've got 1 VELOS, which is an orthopedic robot. The department says it wants to grow robotic surgery and be competitive in this space, but wants to do so in a cost-effective way. And they've acknowledged that the robotic surgery landscape has started to grow in Canada, and the absence of acquiring a robot will put you at a disadvantage in high-density urban cities. So how do you do so? Well, I would say continue to think about the strategy. How does it differentiate you? How do you want to be a competitive facility? How do you want to think about fleet acquisition in the future as opposed to now? And then thinking about different procurement models. You can either buy the robot, you can finance it, or you can do this novel pay-per-use. And this slide just breaks down a bit of the different pros and cons with each. So I would say about 10 or 20 years ago, purchasing was the way to go. People bought the robot. It was a one-time capital investment. Philanthropy loves this, but you were subject to the ongoing operational costs. And this is the trap we fell into with relying on donors to pay for the disposals. You risk obsolescence because once that robot becomes better than its best before date, you're stuck with it. A lease agreement, might help you mitigate the one-time capital outlay, but it increased your operating costs and you're coupled in with service contracts and you don't own the fixed asset. So at the end of the leasing term, you're left with nothing. What I think is coming down the pike that I think folks on this call should be aware of is this pay-per-use model. It's a bit of a blend between purchasing and leasing that allows you to actually commit to volumes based on your case mix and actually add that to your case costs. And Amir and Maria, I'll spend more time in the question and answers to go over some of this as well. There are some risks and dependencies. What are cases that are funding? How much foundation commitment do you have? If the volumes don't materialize, then what? And what's your growth strategy? So all of these things I do think need to be contemplated. I know it's a lot to unpackage in a very short period of time. I know I spoke very quickly, but Maria, Amir, happy to have additional conversation. I always love ending with this slide. When I learned how to do robotic surgery in 2010, 11 in Hong Kong, I remember coming back home and my mom saying to me, so if the robot is operating, what are you going to do? And I tried to explain to her that it's not a robot itself. It's really augmented surgery. And I think the ultimate iterations of this as we advance forward is integration of imaging, AI, and other features that'll make this the platform for the future. So thanks for your time and happy to enter into dialogue.
That's awesome. Thank you. I think we'll leave the questions at the end because I think there's going to be a lot of overlap between the topics. So our next speaker is Dr. Sunil Patel, who is a colorectal surgeon at Kingston, also an associate professor. So Sunil is going to talk to us. Okay, so we got the robot. Now what?
Okay, so yep, just sharing my screen now. Hopefully you guys can see that. I have to apologize. My video has been cutting in and off specifically on Zoom. So if I go away, that's why. So thank you for that introduction. And thank you, Amir and Maria, for inviting me to speak today. I think this is a great platform and it's always very wonderful to see or hear Fayez speak. I always learn so much from him and actually his beautiful slides. I don't have his beautiful slides, so I'm going to figure out what program he was using after the fact. So I was asked to speak a little bit about we've got the robot, now what? How to maintain and sustain a robotic colorectal program. And I think this, complements what Fayez spoke about. I would put some disclaimers. So I'm going to give some examples of what worked for us in Kingston, and it may not always fit with your local practices, your local pressures, surgeons, volumes, etc. But I think there's some common themes and lessons that can be learned. And I always put this picture along the bottom because I always think that I'm on the far right. Some of my colleagues maybe are more in the middle, and then obviously the orthopedic surgeons are far on the left. I've made that joke many times before, and I will continue to do so. So the objectives really were to show how to show value in robotic surgery, how to create a sustainable program, how to grow your program, and how to onboard new surgeons. And I think that these are all related in different ways, and they're kind of one topic. That's how I'm going to look at it. And just a bit of background, this is the practice where me and Amir work. It's Kingston Health Sciences Center. We're the single tertiary care center for the region. It's one of the smaller regions in the province, but there's still a referral population, about 700,000 patients. There's our hospital on the waterfront. The colorectal program is 3 surgeons, myself, Amir, and Hugh McDonald. We get access to about 2 robotics days a week as a group, and we're kind of typically, well, now our new kind of normal is about 150 to 180 cases a year. And we've made the conscious decision to basically switch to robotics as our approach of choice. So we've largely abandoned laparoscopic surgery, and we really will use robotics for any major colorectal procedure. And so getting to that point, I think goes back to the objectives that Maria and Amir asked me to talk about. So showing value, sustaining your program, growing your program, and bringing on new surgeons. And I think really the crux of all this is showing the value of robotic surgery. This isn't always obvious to Canadian audience, Canadian hospital admins, and this is something that nothing can be done until you show the value. And so part of showing the value is justifying why you want to start a robotic program in the first place. And I think articulating this is really important. And some of our motivations are here. I think this is probably very similar to what many people on the call would like to do. You want to improve your outcomes, improve the type of MIS surgery you're doing, the complexity of your MIS surgery. Early adopters, I think we're still kind of at that point. Maybe we're in the chasm, as Fayez talked about. And this is a great chart. Fayez put this up, and I think he eloquently talked about where we're at. I think we're starting to move out of the chasm and starting to move more towards the right side, which I think is fantastic. So why would your hospital support a robotics program? I think Fayez talked a little bit about how you have to align your desire to start a robotics program with what the hospital's mission is. And I think our hospital is not unique. There's always in the mission statement and the visions about innovation, improving access to care, et cetera, et cetera, et cetera. And I think that's something that really can be leveraged when you're talking about maintaining and growing your program, is how does this fit into what the hospital's vision of who they are and where they want to be? And I think overall, most hospitals are looking to provide high quality care. And I think they want to be known as a setting that can provide innovative care for their patients, because this is what patients demand regardless of the setting. Part of going forward with this is really understanding, what does success mean to you and what does it mean to the hospital? Defining success can be challenging. Is it just doing more cases? Is it doing more minimally invasive cases? Is it reducing wait times? What's success for you and your program? Who's defining success? Is it you? Is it your department head? Is it the hospital executive? Is it some perioperative committee? And how do you measure this success? And this is a very important concept, at least we found, for maintaining and growing our program. Because if you can demonstrate success, usually resources and access follow. If you cannot demonstrate success, or you're not even measuring success, it can be very challenging to try to keep your program going, grow your program, and move it into the spot that you really want to be. One of the things that we think is essential, and I think many people on the panel will agree, is having some sort of committee. We call it the Robotic Assisted Surgery Committee, that kind of oversees robotic programs across specialties. It's a great forum to discuss what the priorities are, what the requirements of a new service or a new surgeon are, how to allocate the robotic platform, and really have like a consensus and collaborative view on what this really expensive resource should be used for and how we can ensure that it's being used as we want it. Showing the value of robotics is challenging, because most people think of the cost of robotics. And so when you say, what's the value of this? Really, people are asking us, what's the cost? How much does it cost? How many millions of dollars is the platform, and what does it cost per case? But that's not really what value is. And I'm no expert in this field, but pretty clearly, something can be more costly, but if the outcomes are better, it's definitely justifiable. And I think that's where we're moving with the robotics. It may be more expensive, but it may provide better outcomes for your patients, which thus makes it a highly valued resource, and one that should be supported. Intuitive and Da Vinci sometimes does themselves a disservice. Like, you look at these promotional pictures from the brochure, and it looks like you're buying a new MacBook or a Tesla or something. And when I spoke to our CEO, who's David Pecora, he's an orthopedic surgeon. When he looks at all this, he turns to me and says, that looks very expensive. When we first started the program and I was showing him instruments and talking about what we can do, that looks expensive. And it does look expensive, and it can be very expensive. And so you're constantly fighting against this perception of high cost of robotic surgery and how it relates to other programs. And your intraoperative costs will be scrutinized. And so when you're trying to show value, this is what people will think about. That looks more expensive. The other cost savings may be ignored. I always star this because this was really something we fought against in 2019 and in early 2020. Once COVID hit, it seemed like length of stay, emergency department visits, and inpatient hospital resources became much more valuable, even though they couldn't necessarily what they describe as monetizing it or putting a dollar value on it. Just the resource and the capacity was important. And the other thing that's I think we've found, and I'm sure others on this call have as well, is that you're constantly being compared to robotic surgery or laparoscopic surgery. But the problem with that comparison is laparoscopic surgery costs are rarely really captured in a way that's meaningful or that's accessible. You know, things come in and out of the ORs. Many OR staplers get opened and thrown out, not used, etc. Like they don't capture the cost of laparoscopic instruments very well, especially the disposals, because they're shared across many different specialties for many different indications. They can't attribute it to just your case necessarily. In addition, like everyone talks about the cost of the robotic and buying the robot, but no one talks about the cost of lap towers and laparoscopic instruments. There is a cost for it. It's not as expensive as robotics, but it's often ignored. So you're kind of fighting this perception that robotics is more, but the comparator is not necessarily captured correctly. And I think, you know, this is something that we've really learned in Kingston, and something that our group has really worked with the hospital is understanding our costs. What is the cost of a case? Like, how do you know what that is and whether you're doing a good job or a bad job? If you don't measure it, if you don't report it and you're not aware of it, you won't know where you sit. In Ontario, at least, for Cancer Care Ontario submissions, QBP cases, so the cancer-related volumes where the hospital gets funded per case, they require the hospitals to submit case costing at the end of every fiscal year. So you can actually get this. Is it really accurate? Hard to say, but it's better than nothing. And we have a great relationship at our hospital, at least, where I send an email on Monday, and on Tuesday, they send me a list of all our robotic right colectomies and how much each one cost over the last 2 years. And that's very powerful for us to demonstrate value. If someone's going to off the cuff say it's more expensive, well, I can look and see whether it is. I can get lap, robotic, whatever, and kind of report to whoever's challenging us on what the actual true cost is. And I want to know the cost. I want to make sure that I'm providing value. You know, there's some predictable benefits of robotics. To us, it's really expanding MIS. We know there's value to doing minimally invasive surgery over open surgery, and you don't need to beat a dead horse. You don't need to show that minimally invasive surgery has benefit to the patient over open surgery, but you do need to capture these things. You can't just imply that length of stay is going to be shorter and reduce risk of this, that, or the other thing. It's something that really needs to be captured. And again, this goes back to, for us at least, the Robotic Assisted Surgery Committee, and then some data analytic guys in our hospital that will provide this data routinely for us. I don't have to ask it. It gets reported to us regularly. And every month we get this kind of Excel sheet that categorizes our cases based on how we describe how we want to categorize, and gives us rolling 6 months averages, each month results about things like number of cases, length of stay, readmissions, etc. And this is at our fingertips. I can pull this off our old emails for month over month over month. And if someone asks us, well, what's your readmission rates? I can show them what the baseline is and what our new one is. Are we doing better? Are we doing worse? One thing that Amir and I have often had to discuss is case length. There's the perception that length of case is longer with robotics. We've actually clearly shown in our data that's presented month over month that for left-sided especially, it's about half an hour to 40 minutes shorter length of OR time. Rights, we're not there yet. We're still about 20 minutes longer for robotics. But this is something you can pull at your fingertips and kind of push back against that perception. Things that I like to do, and I think some of this stuff has been alluded to before, is I capture this and report it. I'm in an academic program, and I think this is ripe for publication. And just to, you know, Fayez did a paper, I think 12 years ago, that showed how expensive robotics was. And so I had to do a follow-up paper to show that maybe it's not as expensive as it once was. So that's the point of this type of research. You know, capturing our program goals, you know, we want to expand our MIS capabilities. And this is data that the hospital supplied to us through our clinical databases in combination with what was being reported. And, you know, when we show that our conversion rate for rectal cancer was about 25% for any conversion, whether that's anastomosis, deep dissection, whatever, down to 2%, people listen to that and find that very compelling data. You know, we have clinical outcomes that have been reported, and I think are not surprising to this group. Short length of stay, reduced emergency department visits, and no readmissions. I spoke at the Ontario Surgical Quality Improvement Network just to talk about these successes. I just kind of show this part of the of our program, just where we started in 2018. It was a different time for us in terms of how we used MIS. As a program, we were doing about 2/3 of our cases minimally invasively. And then our like new program now is up in the 95% plus range. And we think that this is like very compelling for our hospital to demonstrate innovation to the board, to fundraisers or whatever. And when I present this data to lay people, they really seem to like that. Cost of care, we've measured our costs and kind of before robots to after, we've actually shown a cost saving. Intraoperative costs are more, but the overall programmatic savings is there. And I put in what the CCO current funded rate is for colorectal cancer surgery. And then there's soon going to be a robotic supplement. Is this totally accurate data? I don't know, but I think when you go to your committees and show that maybe this is actually a cost savings for them and there's some marginal increase in what they get and it can be redistributed to other programs, that's very compelling to a program to sustain and grow your program. I think part of this is promoting your program. This is from our intranet. The hospital wants to promote robotics. It's a new technology. It's an expensive technology. There's fundraisers that are invested in seeing that this is successful. And promoting this is something that should be done by the surgeons. If you don't promote it, no one else will know how to promote it in a way that makes sense to your patients as well as to your colleagues. And we've had some press with this, which has been really helpful because this has really led to some really important fundraising for us. There's still philanthropic donations are an important part of getting the capital, and this leads to that. And I think this can't be understated. You can't just hope that someone's going to give you money. You really need to look and see how you can fundraise for the resources that you want to use. I think maintaining and growing your program extends from that increased resource allocation. You can see members of our team, and I think there's some really important parts of this. Like your program, it will be very challenging to be successful if it's you pulling alone. I think if it's you and your colleagues and the nursing staff and executive and everyone wanting to support your program together, I think it's much easier to make sure that this is a success and that you can grow it. I've witnessed in some programs, if there's only one or two surgeons offering the approach and one or two are not, there can be naysayers. They may be offering a different approach, and the perception within your hospital could be that, well, you could do either or. They're both being offered. Why would we take on robotics as a new program, a new investment? And so I think for us, at least, it has been very important that as a colorectal group, we committed to this and we are all offering the same surgery for the same indications. It's not like the patient gets a different surgery because they go to a different surgeon. And I do think that's really important in terms of equity and showing the value. It's really hard to make the argument that robotic surgery is essential for you, but your partner doesn't need it. Like, that's not a really compelling argument. Onboarding neurosurgeons is a process, and it's something that really requires commitment. There's a picture there at the top of Antonio Casito, who learned robotics at Queen's, and then Amir, who joined us, and we were also able to teach him. Your new surgeons may have robotic surgery skills. I think that's coming, but most still will not. And so how are you going to proctor and mentor your new surgeons? It cannot be you help them for one or two cases and just tell them you'll be available. I really think it needs to be in the room helping, because you do not want your colleague to be spending long times doing robotic challenging surgery on her own. It makes it look like the resource is not being used efficiently. We published when I was in fellowship about the institutional learning curve versus each additional surgeon's learning curve. And I really think that emphasizes it. The first surgeon on your own takes about 80 cases to get through your learning curve. Each additional surgeon, their learning curve drops. And it's not because the surgeon's any better or worse. It's because the nurses are more skilled, they're more familiar, the turnover's better, there's more refinement on the instrumentation setup, et cetera. So I think having a group practice is really important for this, and onboarding your new surgeons is really important. You don't want a new surgeon to come in and not be allowed to have access to the robot which you're using. Promoting your program also increases volume and the indications. We've noticed a huge shift in the referrals. Very few patients in our region now are unaware that robotic surgery is a possibility. They Google their disease and this is what comes up. And so we're seeing increases in our volumes, which means that we need increases in access, and promoting your program and showing value is what you need when this starts to happen. Our original goal was 70 cases a year, and this year we're on track to do about 150 to 160, and next year it'll probably be around 180. And this is through promotion, changes in referral patterns, and how we're offering our surgeries. And we need access for this. That's how we're going to maintain the success. As they say, I think like these things are linked, and what I'm really hoping is that we can shift kind of robotic surgery or colorectal surgery in Canada from kind of the laparoscopic open blend to a more robotic focused. I really am hoping for that. And I put this on every presentation. So there's my email address above. I think Amir will probably circulate this, and I'd be happy to respond to emails. I'm sure there's some questions at the end. So thank you for listening to me, and I'll stop sharing my screen now.
That's awesome. Thank you so much, Sunil. So I thank you on behalf of Amir, who you onboarded to your program as well. So next we're gonna ask Dr. Snelgrove to talk to us a little bit. So now we have the robot. So how does the robot work in action? What are some of the challenges that arise after implementation? The Edmonton program is one of the most long-standing programs using robotics for colorectal surgery in Canada. So it's great to hear you talk about some of these challenges and how to go about them.
Thanks. Are you able to see my screen here? Okay. So thanks. I guess I should thank Fayez for all of this, and it's fair for you to say that we've been doing this for a while, but Sunil launched at the same time, and I wouldn't be here if it weren't for Fayez coming out to help proctor and mentor me and my partner Haile Wang 6 years ago. So I think that kudos goes back to him. So just for context, we do track our numbers as well, like Sunil does, and I think that is really important. Since November of 2018, we've been doing about 1 to 2 cases a week, with the notable exception of 2020 when everything got locked down for a period of time. We've onboarded another partner, Dr. Mark Dijkstra, and we've continued to slowly trend upwards in the number of cases that we do. I'm going to focus my presentation more on the nuts and bolts of the day-to-day stuff. I've been lucky being in Alberta because I haven't had the value challenges that Ontario and other places have. In fact, our management was very supportive of us using the robot because they saw it as, when it was underutilized, they were paying more per case because they looked at it as a waste of the service contract if there were days a week where it wasn't being used. So it was a very different perception than many people have faced, and we were lucky to be in that environment. It really helped us flourish. Over the time, our ROR times have come down. The biggest drop was when we got the newest platform, or the current platform, the XI, where a number of the collisions and other issues with the older robot were eliminated. And currently our time is faster robotically than it is laparoscopically. Along with that, just like with Sunil and Amir's program, our readmission rate has been cut in half. Our length of stay is about 3 days shorter. And so overall, our costs are less per case. And if you include the readmission in the 90 days, it's significantly less. I will point out that one of the arguments I heard against the length of stay decrease being a value is in Canada that actually costs more money, because as soon as that bed is empty, somebody else comes in to use that. And so some of the bean counters don't support that argument, but the readmission data is real. And overall, that knocks your costs down quite a bit. In terms of the cases that we do, it's a lot of distal pelvic surgery. So we do a lot of low rectal cancer with this. This is the first 5 years. I don't have the 2024 numbers yet, but the proportion would be similar. So we do a lot of APRs, low anteriors, total proctocolectomies, low Hartmans, a handful of pelvic exents and pouches, and a small portion of diverticular anterior resections. We've done 1 right hemicolectomy in our early phase. For access reasons and just laparoscopically, we found it didn't really add anything for us. We focus mainly on using it in the pelvis, where we found a bigger advantage. So now getting into some of the kind of day-to-day challenges, I think the biggest challenge is once your program has a robot, or if it has a robot, how do you get it? Urology and gynecology hold that stuff like they bought it themselves, and that can sometimes be a challenge, especially although it's getting a little bit older. The institutional memory was Europe. So even though the health region often replaced it, they still have a sense of ownership with it. So at our site, we have urology. We do not have gynecology. We have us, and we have ear, nose, and throat. And the things that have worked for us, I'd say the biggest thing that worked for us, if you have the choice, is we do not have a dedicated robotic theater. So when I use the robot, I use it in the general surgery theater. When urology uses it, they use it in the urology theater. When ENT uses it, they use it in the ENT theater. The big benefit of that is it makes it really easy to split days. So our numbers, if you look back at them, it's about 3.5 hours for a low anterior, but I only need the robot for a couple hours of that, for making the stoma, for waking the patient up, moving them out. We can do that laparoscopically. If there's an APR, we close the perineal wound. There's time where you don't need the console, where if you had to get out of the room before the next patient got in, they may not start till 1 o'clock, and that would very much limit another use of the robot. So our nurses will actually pack it down, tear down the sterile drapes, and wheel it down the hall to the next theater as soon as we're done with it. So we're often using it between 2 theaters. I would say almost every OR day, it's gone between one theater and the other. And it's allowed access to be a lot easier, and it's allowed less animosity between those services who really want to have access to it, where they don't have to fight for getting their day or readjusting their schedule too much. We've assigned days of the week to services, much like Sunil and I imagine Fayez, and that does help for planning. So currently, urology gets it 3.5 days a week, general surgery gets it 1.5 day a week, and ENT gets a half day that gets alternated back and forth between the general surgery time and the urology time, so that it alternates week to week. And that's useful because if we know we have a rectal cancer or a case that we really want to do robotically, we can schedule it in. Now, that being said, we do use it more than our assigned days. Every service does, because we work together. And if it's assigned to urology and I want to book a case in 2 weeks, I generally just reach out to them and can figure out a time of day that works, because it's not frequent where they're using it for the entire day. They might just use it for the morning, and then I can take it for the afternoon, or vice versa. It does help having the robotic committee, which I'll talk about in a moment, because you get to know each other, and it allows people to be a little bit more flexible in flipping those things around, so that they move their case to the afternoon, or maybe they do a different case than the third prostatectomy. Maybe they do a conduit or something like that. One of the other things that we've done is try to arrange our OR days as divisions so that we don't conflict. So I used to operate on Mondays, for instance, and so did one of the uro-oncologists who did a lot of prostatectomies. And so for years, we were constantly every week trying to juggle things back and forth during our cases, trying to see if we could borrow, et cetera. And so recently, through the robotic committee and through our own site, we switched my OR day to Tuesdays, where urology does reconstruction. So I don't have to compete with somebody else who has a vested interest in that robot on the same day. And so some of the bigger structural or scheduling things can help with that to facilitate use. We do have a robotic committee, just like Kingston. I don't know if Fayez does, but I would really suggest having one. It allows you to throw your numbers out. It allows you to both talk as a group. So we have our surgeon in chief, our OR management, and one member from each of the divisions who goes over it. We go over utilization every quarter, and if there's gaps in utilization. So for instance, if urology is assigned 3.5 days a week, but they're routinely using 2.5 days a week, we may reallocate some of that time to make it a little bit, to increase the utilization. It also allows you to advocate. The OR management, at least in my experience, loves advocating for equipment that multiple divisions are using. It's not like asking for the best microscope that only one plastic surgeon uses for complex hands. Having multiple divisions using this equipment is something they see as a feather in their cap and easier to ask, and seeing that it's utilized, they can advocate higher up for us, and they do support that quite well. The other challenge that you'll face with this is having adequate bedside assistance. It doesn't work if you just wait for the resident du jour to show up. With the new XI, you can kind of get away with some things because there's a stapler and an energy device. But the reality is, if you're going to be on a console, you're not going to be scrubbed, and things can go wrong, or they can just take a lot longer if they don't know how to clean the camera. We recently had an issue in the zone where urology was doing a case with just a nurse bedside assist, and there was an injury with the insertment of an instrument. And so our zone has changed its policy about the type of assistance you have to have, but you need to have a senior level of assistant. Otherwise, your program's really going to flounder. It's going to be really challenging. So again, some of the things that work for us, we routinely will have a second staff in the room. When we first started, this was really useful because we were doing a case to a case and a half a week, but If it was just me one day and next week it was my partner, Dr. Wang, the week after that might have been Dr. Dykstra, you go maybe once or twice a month where you're actually on the console. And what we did is we split the cases up as we were both on our learning curve. Maybe I would do the initial dissection, medialize the sigmoid, isolate the IMA, and then Dr. Wang would get on and do the initial pelvic dissection, and then we'd go back and forth, so we'd increase our touch points on the robot. Since then, it's been useful because it can be really challenging if you don't have adequate assistance. And so we'll generally have each other booked. If we have a resident who's been on our service, like a chief who's been on for 3 or 4 months, who's become a good bedside assistant, then we may just have ourselves available where we book a light clinic, but we plan to pop up for the transection or the anastomosis about mid-morning. But usually there's 2 of us in the room, if not the whole time for most of the time, and that's worked really well for us. Some of the programs in the zone have a dedicated family doc robotic assist. The urologists have that, and that works well for them. I find the assisting, especially in the deep pelvis, and for certain things, is more challenging than for regular laparoscopic assisting. There's more stuff in the way. You can't watch their hands come in, so they need to be able to find their hands. And so you do need a relatively skilled person assisting. So we haven't recruited a family doctor. It also, at least in Alberta, can be challenging to find somebody who just wants to come for 1 or 2 days a week and has an interest in a fairly complex piece of technology, but it can work very well. And then finally, we incorporate residents regularly into it. And I'll talk a little bit about that because we're transitioning now that we've kind of matured in our program into really incorporating residents more formally. So junior residents, when they come through, we have them oriented to the bedside assist role. You can have your robot rep do that for you after hours for a dry lab. But generally, if they don't have a chance for that, we'll just do it ourselves and we'll train them up on that. Our chief residents, we train in that way as well if they haven't had the opportunity, or we refresh them if they haven't been here for a while. But then we really try and get them on the console. And so we'll get them to go through the Da Vinci Trainer basics. We'll show them our approach to doing the case, and then we'll split the case up so that they can do some of it. Now, I talked to the residents recently about this, and they had a number of benefits and cons. They were actually much more supportive than I thought they would be. I thought they'd emphasize the downsides, but they were actually more excited about it, which is nice to know. So they had a number of benefits. First, they can see way better, both open, but I would say even lap. I think your visualization robotically is superior. It's a much more stable image. You can appreciate the anatomy a lot better and see the dissection better. They also found, whether they were assisting or doing it robotically on the console, that afterwards they felt like their lap skills were higher. Now, part of that might be because we have a second staff there. So while they're the bedside assist, if they're not that familiar with it, I might be sitting next to them giving a one-on-one on how to do it. Also talking about the anatomy, talking about the case, going through stuff. So they actually do find that it's quite educational. The other benefit of having a second staff with chief residents is if they're on the console with my partner, I'm at the bedside assist. So the residents don't feel like they can't get on the console because somebody has to be at the bedside and the off-service emerge resident isn't going to do it. And then finally, they are excited to access the new technology. I think, as Sunil pointed out, we're getting to the point where more people are seeing this as something that will likely be part of their practice. And so they like the exposure to it. They like having the ability to practice on it. In terms of the downsides, for them and for us, I think the biggest one is frequency of access for the residents. We have a number of sites they rotate through. The juniors may come through for between 1 to 2 months. They may not come back for several years. The chiefs come for between 1 to 4 months, but then they'll move off somewhere where they don't have access to robotic surgery elsewhere. Given that ours is the only program in the zone, they go for many, many months without using those skills. And so there is some attrition. When they come back, they do reacquire it, but it is a bit of a gap. I think that will change as more access becomes available, but it's the reality of things now. And then the argument that I was expecting to hear that I don't know how to answer is the decreased exposure to lap and open pelvic cases. I mean, this is the same with any new technology, I think. I went through this with laparoscopic colectomies and laparoscopic colon work. I imagine it was the same with lap choles and open choles. Yes, as we do more with this technology, the staff will dominate the learning curve first, and they'll be spending more time on it. And as it's less available, that will seem like a luxury that's taking away from you learning how to do it open or lap. The reality is it's the evolution of the technology. And there is a bit of a curve where You may get some out of it, but where you wouldn't be doing your open or lap bits, but there is lots of other things that we do that incorporate that. So I don't have a good answer for that. I think that's just part of the cost of doing business with new technology. And I think the long game of it is better than the short term of the loss of something which is being lost because we think it's a better way to do it robotically or with advanced MIS. So that's all I had, more of a nuts and bolts day-to-day approach that we use. So I can stop sharing and turn it back over for discussion.
That's amazing. Thank you so much. So I think we have a couple of participants. If there's any questions, feel free to either unmute yourself or send the questions to us and we will send them along. And in the meantime, I guess while we wait, I have some questions. So I guess we mentioned that in some programs, the focus is now very much on robotics. And so laparoscopy sort of loses its place a little bit in the elective algorithm. The question becomes, in the emergency setting, are we then losing the opportunity for laparoscopy use in the emergency setting since robot maybe has not made its way in the algorithm in the emergency setting? So maybe for programs, I think the Kingston program almost exclusively uses robotically now, but not in the emergency setting. Is that correct?
Yeah, so we wouldn't have access for like an emergency sigmoid resection on a Saturday night, for instance. This has been part of a training program challenge, I would say. The way we've dealt with that based on resident feedback and kind of what they want to learn is to incorporate their large community rotation, which is at Oshawa. They have like 3 or 4 colorectal surgeons. And so we've kind of designated that as that's the rotation that they're going to learn the basics and the fundamentals of laparoscopic colorectal surgery, which we think is laparoscopic and robotic is kind of an extension, like 2 sides of the same coin. It's the extension of MIS. I think the other thing that we try to stress, I believe, maybe it's controversial, but emergency colorectal surgery is very different than planned elective colorectal surgery. Your indications are different, your patient population is different. And so I don't think it's the same operation. I think doing an elective sigmoid resection for an early stage cancer is very different than doing a perforated diverticulitis resection. And I would argue that if the proficiency and competence in emergency laparoscopic colorectal surgery is desirable to trainees, really you're going to get that on call in an emergency setting, not in your elective list necessarily. So I know there is some obviously some shared skills and whatnot, but that's kind of the philosophy that we've taken.
Awesome. More in the question of like sort of as someone who wants to start doing robotics, you know, part of the programs will send us to the States to do some of the observerships, but these observerships are like sort of don't necessarily apply in the Canadian setting. And so, you know, I guess that's why ROBOCO is going to become much more important as new surgeons sort of on board. And so we can collaborate and see what the experience has been in the Canadian setting particularly. But do you think there's a time when we're going to be able to have these observerships here? I feel like that's probably going to be much more useful than going somewhere where we're not going to be able to apply half of the things in our current setting.
I mean, I think I saw Ryan and I come out off mute at the same time. Ryan, I'll let you go ahead first, and then I'll jump in after.
Yeah, no, I absolutely think so. And I think that one of the important things within this collaborative is to build capacity for that. I mean, all of our groups have the volume where we can have observerships. If Amir hasn't changed, he's probably recording every single case and annotating it to share video and go over things. I think that it is a different area. I mean, to go back to your first question, last year was the first year in America where there were more robotic general surgery cases than laparoscopic. So it's becoming there that laparoscopy is not taught in the same way at all. It's going to be a lost skill for some surgeons down there, for some trainees. Canada's a long ways away from that, but I think that we do have the capacity within robotics to have proctoring and observerships and collaborations, just knowledge-wise and technique-wise across the country. I think we've got a critical mass of that already, and as it grows, I think it'll just get more rich.
Yeah, I'll just amplify Ryan's comments. I completely agree, and I think it would behoove us not to demand that actually from the vendors that are bringing the technology forward, to say we actually want to go to a partner institution in a Canadian context as opposed to the US. I think they've got conduits and relationships with US centers, and that's why the majority of folks will go there. But to Ryan's point, I think we've got a critical mass and volume that you could easily arrange both proctorship as well as observership within Canada. It may not be in your city or in your province, but we certainly could across Canada provide that. I've recently kind of gone through an interesting experience. So I initially did my robotics training in 2010 or 11. And then about a year and a half ago, trained on the Hugo device. So we at UHN, we've got the new player in the market, which is the Medtronic Hugo platform, which in many ways resembles a lot in its feel to the initial S robotic platform. But we had to go south of the border to learn the technology, and we've paired as a two-surgeon approach to do all of our cases as we've overcome a new learning curve. So actually, when you're on the console, it feels the same. It feels very similar, but the docking and the articulation and the dock angles are new in learning, and that's where we have value by having two surgeons calibrate that, and our speed has gotten way better. But it's been really fun to learn a new platform, the benefit of which is that it's driven the price structure significantly different, certainly in Ontario, than it was even a year and a half ago. So I think as new entrants come into the marketplace, there will be benefits for us overall with pushing the adoption of technology and bringing more cases online.
Yeah, and Marie, I think your point about observing in the States is not valuable for Canadians. Like Intuitive has a conflict in that they want you to go down and see someone that's using the most expensive technology that may not be necessary. And that when we talk about value and cost, you need a vessel sealer and scissors and 5 different things? Probably not. And you really need to be cost conscious. So we've pushed the agenda with Intuitive and the reps that we interact with, that we want Canadians to come to us or Fayez or Ryan or wherever to see what we're doing. And when they need a proctor, we want Canadian proctors. We don't want people from LA coming up and showing you how to use 15 stapler fires and 3 vessel sealers and things. So I think that comes from the surgeon. They have their own requirements in terms of who can proctor, where you can do observerships. That's their own internal kind of rules. It's not our rules. And I think we just have to continue to push that. We are Canadian surgeons in a Canadian context, and we want to see what Canadians are doing.
Yeah, I think that's very, very important. I agree. I think Amir had a question.
Yeah, I'll just remind everyone that you can now unmute yourself. I think Mark Dykstra really wanted to be able to say some things initially at the beginning of I'm just kidding with Mark, but I'm just going to remind everyone, all the participants, that you can actually unmute yourself and just participate. We were really hoping to generate some discussion and really hopefully folks that are on the call. I'm not going to pick on people too much, but I hope people can ask some of the hard questions, because I think that's the kind of level of discussion that we need to have to make this implementation of robotics successful. Let me ask Fayez, one of the things that I kind of took my head a little while to wrap my head around is this whole concept of QBP funding or value-based care or case bundling. Can you just explain that concept and maybe just frame it for how do hospitals sort of evaluate the costs of care? Like when you say that there's case bundling, can you explain that concept a little bit? Because I think that's very valuable when you're trying to think about the costs per case for the robot.
Yeah, thanks for the question, and it's a bit of a complicated answer. So I'm going to step back and just, for the Ontario context, explain how we're funded. So I would say in the first iteration, the government used to fund us with a bundle of money. So you got $100, do all the activity in your hospital with the $100 that we've given you. And then the ministry said, well, that's not exactly the way that we want to do it, because we want to drive specific activities and volumes. So we're going to blend you through a combination of select case types or incrementally funded activity so that we're driving and pushing volumes. So we're going to pay you a bundle of X dollar. We're going to pay you X for the X cases that you do, but we're going to carve it out of your 100. So now you get $85 in order to do the activities you had previously globally funded, and $15 we're going to allocate to the incremental activity that you do. So it's not like the dollar or the pie got bigger, it just became siphoned in a different way. And then the ministry said, okay, well, we're going to be even more clever. Instead of just paying you for incremental activity, we're going to give you the cost of what we're going to pay you for what it costs you to do the activity in a QBP model. So QBP is quality-based procedures, and it's a bit of an end-to-end provision, meaning that you get paid for the procedure itself plus that hospitalization. And instead of now the $85, we're going to carve out 25 of those or 35 of those dollars to be allocated to QBP. So now 15 to some of the incremental volumes, 35 for QBP, and 50 for your base. Of that 35, what they do on an annual basis is they refine the funding envelope based on what it actually costs you to deliver the care. So in year one, they did a cost estimate on what you spent on each of those activities, and they reimbursed you for that. Year two, and as hospitals, we said we're going to drive down our cost, and the margin that we're going to get on the reimbursement relative to what it cost us, we're going to pocket and use for other activity in the organization. Now, the truth of it is, we're not profits generating centers. We're using it to offset deficits in other areas. But the ministry is clever, and it says, well, it actually only cost you X, and you got X plus Y last year. We're going to pay you X this year. And so what did the hospital do? Okay, we're going to be more efficient, and we're going to drive our cost to X minus Y now. And the margin, we're going to pocket to offset some of the other costs, to the point where you've actually squeezed the organizations down to the lowest cost provision for that activity. And so what they've done is they haven't just looked at your organization alone, but they've looked across hospitals in Ontario and taken the average lowest cost provider in order to reimburse you. It's a long-winded way to say that the reimbursement structure is not unique to your institution. And so as you think about what your spend is, to Sunil's earlier point, you have to be quite cost conscious and not just look at the expense within one sphere of the episode, but how long are those patients staying? Are they utilizing ICU care? Are they being transfused? Because all of that is bundled in one package. Robotic surgery is an interesting one because at present, the way that we're reimbursed for QBP is either through open or laparoscopy. And now there's an additional one coming down the pike for incremental investment for robotic interventions. They've done so for prostate, elevated BMI, gynae procedures, as well as partial nephrectomy. There's word that there'll be reimbursement for colorectal, for some head and neck cancers, and for lung that's supposed to come out this fiscal, but that yet hasn't been described. But laparoscopy to robotics, for the most part, historically in significant laparoscopy centers, there's still a delta on the disposables on the robots. So each case has lost a small proportion. What we've done in our organization is we've taken the margin on prostate and kidney and used it to offset the costs for robot, for colorectal, head and neck, thoracics, and others. And that's how we kept our robotic program in a stable funding position. I know, Mir, that's a long-winded way to describe some of the complexities, but if there are programs out there that are looking to say, how do we make the dollars and cents float? I'm happy to even offline talk a bit more granularly about what those dollars look like, and to maybe go over a bit of a spreadsheet to think through the dollars and cents.
Yeah, I think that's super, super helpful. And it clearly, obviously, context specific, like the challenges that Ryan has had, it might be slightly different, obviously, than Sunil and you have had in implementing a robotic program. Maybe I'll open it up to all three of you. I mean, obviously, a big part of this is dealing with industry, and sometimes I wonder whether, we could be a bit more aggressive in demanding some value from these industry partners. And I'm kind of in a way glad that you've started adopting other competitors, because I think Intuitive having a stranglehold over the market is not good in terms of driving down costs and things like that. So maybe I'll ask Ryan. Ryan, when you started the program, I'm sure the Intuitive was trying to get you to use all the different instruments. How did you sort of navigate that interaction? How does the interaction go currently? Are you in close contact with your rep all the time, and they give you good sort of service and that kind of thing? How do you have any advice for dealing with the industry side of this?
Yeah, well, I would say that the reps, like all reps, are variable. Our initial rep was excellent, to the point where he actually came to a bunch of cases, and was almost like a caddy. He had watched the videos online and was like offering tips about like how to retract, in a way that wasn't irritating. Our current rep we haven't seen for quite some time. He's a little bit less available. I do double duty as the medical director for our sim lab, and so I do interact with like all of the reps for funding for those simulations because it's entirely soft money. The university's not putting much up. Um, I think one of the things that we try to be cognizant of is not really taking advice from the rep. Generally, we would talk to either our urology partners or our ENT partners or Fayez or you guys about, if we wanted to try different. I mean, we've had discussions about the lap staplers versus the robotic staplers almost every time we sit down. Like, when do you pick one over the other, cost wise, number wise, et cetera. And so I think that getting the actual nuts and bolts of the cost, and then sitting down and trying to figure out the advantages and whether there is a justifiable cost or whether it's not justifiable and you should use a substitute like a laparoscopic energy device or a laparoscopic stapler. I do think that one of the things that we have probably all tried to do is be a little bit distant from the things that they offer, because I mean, they've offered to pay for research assistance, to like generate publications for us, like different things that kind of we felt would both muddy the water, but we're kind of a little bit dirty in terms of trying to promote it. So I think that, like Fayez said earlier, it is a bit of a razor's edge. I depend on like all of them, Stryker, Ethicon, et cetera, for the simulation to support resident education. Intuitive's no dissimilar. Like, I'm approaching all of them to try and get an expansion in our lab. And there's also a traveling robot that comes through, so to try and fund an educational event with the robot. So I think that the unfortunate truth is that the money is not there for a lot of support for that sort of thing from universities anymore. And we do depend on industry in some ways, but I think having the intellectual property and the freedom to control what you pick and what you do is really important with it.
Yeah, Amir, can I just follow on what Brian said as well? Like, I think they're very invested in making you or having you try to use lots of different instruments and disposables and expand your use, go into this field, this realm or that realm. I think you have to recognize what they can do for you and what they'll want to do. And we use them to give our residents and trainees what we call a mini robotic boot camp. So education is very valuable. No one knows the technology better than them, in terms of error messages, setting up, etc. So it's really important to make use of that. Have them be a partner with you in promoting or to educating your residents and getting them facile so they can use it. I think as well, take advantage of the courses they offered and the practice sessions and the simulators and traveling on site to their locations to learn from some really like world experts. They're quite willing to fly people down, and so you don't have to pay out of pocket. And I don't think that that's necessarily going to influence what you do necessarily. It could, but I think it's something that you can really take advantage of, is use the education and the expertise in it very well. And then I think as well, demand that the reps are on board, on site, helping you and your nursing staff troubleshoot. They're all over you before, like as you get the robot, when it's first implemented. And then what we've noticed is that depending on the reps, they can be largely absent once you have a mature program. And that's the exact opposite of what you want, especially when you're paying for a large service contract. I think you really need to demand that they provide the service that you need, because it's often things like a cord is broken, the new nurse doesn't know how to set up this or the other thing, or you don't understand the error messages, or it's like it seems like someone like crashed into it with a car or something. Like, you just want to make sure that they're servicing the product in a way that you can use it and not have to replace it earlier than you want. So I think those are some of the lessons that we've learned.
Well, thank you all, and to everyone who's on the call today. I recognize that it's getting late, and I'm sure I could pick all three of your brains and chat about this endlessly. But we'll wrap it up for today. Once again, thanks again to all the participants, and particularly our panelists, for presenting their thoughts on a challenging but exciting topic. And we hope more folks will join the collaborative, and we look forward to doing more webinars in the future. So thank you, and have a great night.
Thank you, Amir and Maria, for putting this together. Really, really amazing initiative.
Thank you, Fayez.
Thank you, Sunil, for his idea.